to connect because I could connect, but I could see you, but you were not serious. Thank you, Wayne. And let me just join you in extending my sincere apologies to the group. And maybe I will also suggest that the meetings, this briefing be shifted to 11:30 every week so that we give room for the permanent representative, since they are becoming more and more keen to hear the updates. And I don't want to be delaying, so that I just, I mean, it happened last week and this week. It would suggest to me that it makes sense for us to shift our briefing slightly, maybe by 1 hour going forward, if this will be okay with everybody. That way we give sufficient room because you cannot determine what they are going to say. There are usually 55 ambassadors and everybody has a question for you after the briefing, and you cannot abandon that. So again, my sincere apology, but we'll fix this so that going forward, we can either shift it to 12 o'clock, which will give sufficient buffer for that, for the PRC discussions to take place. So good morning again, colleagues. Once more, I will do the usual thing, look at the epidemiological situation on the continent, and then review for you what we are doing as Africa CDC, and then end up with the vaccine and vaccination situation. So first of all, what is the situation epidemiologically? As a continent, we have, as of today, reported 4.4 million cases of COVID-19, which accounts for about 3.1% of the overall global numbers. Of that number, we know that about 4 million people have recovered, representing a recovery rate of 90%. 118,000 people have died, unfortunately, and representing a case fatality ratio of 2.7%, which has remained stable over the last couple of months. The global case fatality ratio is now at 2.1%. So I think that tells you that we have to keep improving on our case management situation for the continent. With respect to the situation of the variants, there has been no really changes yet. Since last week, we have reported that, or not observed that there are 19 countries with a B117 variant, and there are 18 countries with a B1351 variant, and some countries are reporting the mixture of this variant. Suffice to say that the B1351 variant is predominantly around the southern African countries in that area, with the exception of, say, some countries a little bit further up in West Africa, like Cameroon, Ghana. I've also reported that, but otherwise it's predominantly in that part of the continent. So when you look at last week, which was the week 14, and you compare the epidemiological week 14, and you compare it to this week, which is 15, what is the trend? We noticed that overall, the number of cases decreased by 0.1% from last week, and this represents 78,000 new cases, with the highest proportion of new cases reported from North Africa, that is 34%, Southern Africa 19%, West Africa 7%, and Central Africa 3%. The following 5 countries are reporting the highest number of new cases on the continent: Tunisia, with 14,000, Ethiopia 13,000, South Africa 8,000, Kenya 5,000, Egypt 5.8 thousand. In terms of deaths, that is again compared to last week, before I go to the 4 weeks, we recorded an overall total of 2,100 new deaths across the continent. And that represents a 15% increase compared to the previous week. Now, when we look at the 4 weeks, the past 4 weeks, say what is the trend in that? We notice that overall, there have been a 1% average increase in new cases, that is over the past 4 weeks. The following breakdown can be observed for the most populous countries on the continent: 7% average increase in Egypt, 3% average increase in Ethiopia, 1% average increase in South Africa. 3 countries, that is amongst our most populous countries, are recording a decrease: 1% average decrease in DRC, 5% average decrease in Kenya, 19% average decrease in Nigeria. I would like to point out to the Kenya situation that this is very encouraging news, because we know that Kenya has just gone through a very aggressive third wave, which with a peak that, if you recall, the peak of the second wave in Kenya was higher than the first wave. So this is very encouraging to see that over the last a couple of weeks, Kenya is beginning to bring down, bend the curve from the peak, going down slowly. So let's now shift our attention to the testing. As of today, about 42 million tests have been conducted across the continent. That represents about 1.5% increase from last week. Africa CDC rolled out 2.6 million antigen tests across 12 member states. As of today, the total positivity rate and the test per case ratio is 10. That is, total positivity rate is 10.4%, and test per case ratio is 10. That number is significant because the WHO requires that for testing to be considered sufficient, you have to be testing about 10 tests per case ratio. So I think that is good news. It shows that we are making good progress. Let me now turn my attention to the work we are doing in continuing to conduct training for vaccination across the continent. We have now rolled out, continue to roll out our training of trainers for COVID-19 vaccines in other countries, including in Madagascar and in Chad, where last week we trained over 80 frontline healthcare workers. And to date, a total of 634 frontline healthcare workers have been trained on COVID vaccines across the continent using the tools that we have developed. And we plan to scale that up using different media and training workshops. So let me now go to the third part of our discussion, which is the situation with COVID-19 vaccine on the continent. First of all, I will say that we now have our dashboard has gone live. We encourage you to go to our website and explore the dashboard for COVID-19. That tells you what the total number of vaccinations is, which country is using which vaccines, how many have they vaccinated. So we'll continue to update that regularly. So please, we strongly encourage that you go to visit the website. And if you have any problems navigating that, email it to us or call us, and we'll be happy to use your comments to continue to strengthen and enhance the user friendliness of the website. As of 19 April this year, a total of 36.2 million vaccine doses have been acquired by member states, with approximately 15 million doses being administered. That corresponds to a coverage of about 0.8% at the continental level, with 0.34% of population having received a full vaccination regime. So you can see that we are still far away from our target. A continental target is to immunize about 60% of our population. And that data puts it in context that we are a long way from getting to where we are. So in terms of the top 5 countries that have administered the most COVID-19 vaccines or attained the highest population coverage on the continent, and I'll go through the 5 slowly, which is very encouraging. Seychelles has administered about 168,000 doses of vaccines. That represents 64.5% of the population that are fully vaccinated. Morocco has administered 8.8 million doses. That is 11.3% of the population, and 11.3% of the population has been fully vaccinated. So 8.8 million doses with 11% of the population fully vaccinated. Rwanda has administered 349,000 doses of vaccines with 3.7% of the population vaccinated. Ghana has administered 681,000 doses of vaccines and 2.4% of the population vaccinated. Nigeria has administered 1 million doses with 26% of the supplies, with 0.53% of the population vaccinated. So let me go to the DRC. Started its vaccination campaign on the 19th of this month with the AstraZeneca vaccines. They had halted that for some time, and we hope that that will be that vaccination campaign will go on well. So last week we published a statement on to member states concerning the rare events related to the Johnson & Johnson vaccine. And I think we are going to be updating those recommendations for the Johnson & Johnson vaccines to issue new guidance based on what the recommendations from the European Medicine Agency have been issued. And you all know that South Africa has now lifted the ban, that the temporary pause that they place on the use of the Johnson & Johnson vaccine. And you all know we published a statement yesterday on the situation to clarify the situation concerning the distribution of the AstraZeneca vaccines that we distributed to 13 member states. And I think we hope that we can continue to work with you all to be sure that this information is translated adequately. So I think I'll end there for now and we'll turn it back to you.
Thank you very much, John, for that briefing. Now, colleagues, we've come to our question and answer session. And if you want to ask a question, please use the WhatsApp number +251 945 502 310. The number again, it is +251 945 502 310. You can also join us live on this platform, as well as send in your questions through the Q&A section. Now, diving straight into our questions, we have the first question coming from Coletta Wanjohi, who is with FSN, and she's talking about something that you mentioned just now in your briefing. So she says, Dr. John, kindly give us an update on the Africa CDC's decision on the usage of Johnson & Johnson vaccines on the continent, given the pause in the United States. And then secondly, she says, are we still on course to acquire the 400 million doses? So those are two questions from Coletta Wanjohi.
So Coletta, as usual, very good questions. We will be issuing a statement today concerning today or tomorrow latest concerning the Johnson & Johnson, the pause on the Johnson & Johnson, and which will be a statement that is aligned with what those who have reviewed extensive data have indicated, like the European Medicine Agency and others. And it's essentially saying that there is the benefit of the use of the vaccine outweighs the risk. Remember what we're dealing with here. So in the United States, where the vaccine was predominantly used, 6.6 million people were vaccinated. And of that, 6 individuals developed a rare blood clotting. So if you plot that into a simple risk analysis, it shows that 1 in 1 million people had the risk of developing the blood clot in there. I think that is extremely important to put that in the right context. And on that note, Coletta, let me also use this opportunity to discuss other risks for things that we do every day as human beings. So if you take the Johnson & Johnson vaccine, and based on the data that we have, 6 out of, you get a blood clot possibility in 1 out of 1 million vaccination. That represents a risk of 0.0001. Okay, that is the risk that you have there. Again, I repeat, a risk of 0.0001. If this morning you're a young woman and you take your birth control pills, there's a chance that, and out of 100 million take that, there's a chance that 500 to 1,000 women will have a blood clot because of the birth control pill. That becomes, again, remember, for this Johnson & Johnson, it was 1 out of 1 million. For birth control pills, it would be like 500 to 1,000 out of 1 million. That gives you a risk of about 0.01. If this morning you're a smoker, you dash at a little corner at the parking lot and you take a cigarette, the risk you put in yourself for blood clotting out of 1,000 people that will smoke is about 1,700. Okay, there is 1,700 blood clotting may occur out of about 1 million people that smoke. If you now don't take your vaccine, your COVID vaccine, the risk is 165,000 deaths out of 1 million infections. That represents a significant risk already of that is what we're dealing with. So that is what we are dealing with. This morning, when I got up this morning and took my hypertensive drug, 1 tablet, I was running a risk of 14 side effects from that one drug, 14 side effects. And I do that every day, and I'm sure others do it. That just tells you that you have to always balance what it is that you are taking, whether it's vitamin. If you take vitamin C this morning today, which most of us take, the risk that you are running is that you may have a kidney stone if you don't drink a lot of water, and that can be extremely painful and lead to hospitalization. So I just want to make sure that we put all this risk analysis in context, that there's nothing that you do, even the vitamins that you take have some their own side effects. Are we on course on getting the 400 million Johnson & Johnson? Absolutely, yes. We've signed the contracts. We are mobilizing countries to go in and get their doses as much as possible. So I think we are on course for the Johnson & Johnson doses. Our challenge is really to continue to push and be hopeful that the early deliveries can happen so that we can actually start immunizing our population with that vaccine. Because for me, it is a very good programmatic vaccine because it requires 1 shot and has a very good efficacy and safety data. Thank you.
Thank you, John. Our next question is coming from Cara Anna, who is with Associated Press. And she says, what would you like the United States to do with any surplus COVID-19 vaccines in relation to African countries? If you are calling for the US to donate them, how much, how many, and how soon?
Wonderful question, Cara. I mean, so the answer there is yes, please. And I'll add a please to it, to the United States, any excess vaccines, please donate it to us now so that we can start using it. Because again, this is an unusual situation that we're dealing with. It is not routine vaccination of, say, measles, diphtheria, meningitis, where we take our time. If we truly have to defeat this pandemic, which we have to for our own survival and also the survival of economies, we have to do that at speed and at scale. So I would be saying that we are in need of from now to the end of the year to vaccinate at least 30% of our population. Okay, if we have to have a chance of breaking the backbone of this pandemic, 30% of our eligible population. And the math is easy, Kara. If you look at our needs, we currently are in, our target was to immunize up to 750 million people on the continent. And as I indicated today, the continent has acquired already about 36 million doses of vaccines on the continent, as I indicated earlier, 36 million. So there is a gap right there. If we have to vaccinate adequately to the end of the year, I mean, we needed of about 700 million doses of vaccines. I mean, we are at 36 million. You can do the math and see where the gaps are already. So I think, and doing it urgently is key. If we delay, what will happen? If we delay the pandemic, the virus seeds itself into other remote areas, and into very vulnerable populations, into areas of conflict, it becomes difficult to vaccinate there. The vast majority of our infections, or what I call the caseload of the virus, is still in the capital cities or major cities, or let me use the word major cities. Ethiopia, for example, in Addis Ababa, about 60 to 70% of the caseloads are still here. Okay, so if we were to have access to those excess doses of vaccines from the United States or from Canada or the UK, then we can vaccinate at scale and break the backbone of the pandemic right here in Addis Ababa before it has the chance to spread into the different parts of the country. So I think, I believe and hope I answered your questions.
All right, let's move on to Sarah Jerving, and she's with DEVEX. She says the Serum Institute of India issued a statement yesterday saying that over the next 2 months, it will devote 100% of its capacity to local demand. How will that impact COVAX shipments to the African continent?
So, Sarah, that is the concern that we discussed last week and the other week about the continent's situation being very dicey. And I mean, the COVAX facility was relying tremendously on the doses from the Serum Institute to meet our vaccination. And if what you just stated, and I haven't had the privilege of reading that statement, is valid, then it means that it will really put off our vaccination programming for a couple of months. I think, and that is not good for for the pandemic, to fight the pandemic, as I have said. So I really hope that the COVAX is looking at other sources of vaccines, like maybe exploring the site in North Korea that also produces AstraZeneca vaccines, and other sites there. So it would definitely, the situation in India will absolutely impact the predictability and the speed and scale of which we can roll out our vaccines on the continent until June timeline, or July, the third quarter, to be very specific, when we begin to get the Johnson & Johnson doses.
Thank you very much, John. Let's move to someone who is online, and that is David Pilling, and he is with the Financial Times. Good morning, David. David, good morning. Okay, I think, all right, David is now offering to type his question. I think he's having problems coming through. So yes, please, David, go ahead and type your question. In the meantime, let's move on to other questions that we have received. And Paul Adepoju with The Lancet has come to us, and he has 2 questions. So firstly, he says, what is the status of vaccine rollout in Africa's conflict zones? So the status of the vaccine rollout in Africa's conflict zones, that's the first question. The second one is, there are still some travel bans targeting some African countries. What are your thoughts on this issue? And what can the affected countries do to address this issue?
So thank you, Paul. Unfortunately, I cannot give you any concrete and useful information on the vaccination in conflict zones because of very limited availability of vaccines that the continent has received. I don't think we are even at a point where you're thinking of spreading that into conflict zones. I think most vaccinations are still happening in major cities, which makes sense. That is where the enemy is. You take the war to where the enemy is. The enemy is mainly now in major cities. It's not to say that they are not. COVID is not happening in remote areas, but it is still mainly in major cities based on the epidemiological data that we have. And that is what I was saying. And in response to, I think the question was from Kara, Anna, that when do we need the vaccines and how soon and important is that if we vaccinate at scale through, say, partnership with the United States government and other governments, the support us, then we will not need to bother about the conflict region because we would create herd immunity very early on by vaccinating a large chunk of the populations in major cities, and there will be then that will give us time to do what I call a mop-up operations in those conflict areas and just vaccinate there with it. Will give you the pace and the time to do that other vaccinate. But you need to have the vaccines before you start planning on vaccinating in the remote areas. Travel bans are really we completely discourage any policies that impose travel bans on people. We should fight the virus and not people. I think, and we know what to do. I mean, that if we just say that you need a negative COVID test, and I'll add to that a valid negative COVID test, that should be enough to allow people to travel freely. Because if you vaccinate, if you get your negative test, it is very possible that you will, of course, travel within the next 2 days or so, or 3 days. It's a clear proof that you are negative. We have on our platform, that is the Africa CDC Trusted Travel, a whole network of labs, airlines that are already beginning to use the trusted travel. So there is absolutely no reason why somebody should be banned from traveling to those areas, to other countries because of they are coming from a particular country there. We should be using science, evidence, and sound public health practice to guide any policy and political decisions. Otherwise, it will be extremely difficult for all of us to come out of this pandemic.
Thank you very much. Let's move on to Peter Mwai, who is with the BBC. Peter says, regarding the expiry date of the AstraZeneca doses that the African Union distributed to various countries through the MTN Group partnership, last week you had said that the Serum Institute had indicated that they could be usable up to June or July of this year. I have seen reports from India that they were extending the shelf life to 9 months, although that had not been approved by the WHO. Does this mean that they are working with the new shelf life, which was adding 3 months? So Peter has a number of other questions, but that one was quite long, so perhaps we'll give you the chance to respond to that one.
No, thank you, Peter, for bringing that issue back. Let me say a few things. That the vaccine landscape, as we have all discussed and we all know, is extremely challenging for our continent, extremely challenging. And we are doing everything we can to get to go to war with what we have. Okay, you don't go to war with what you need, you go to war with what you have. I think we acquired those vaccines through the MTN donation. And at that time, countries were advised that the shelf life, as indicated on the labeling from the Serum Institute, was the 13th of April. We tried to deliver it like weeks before that, assuming that there were small doses that were targeting healthcare workers. And the intent was to immunize, use those vaccines quickly. And if you just say you're immunizing about 10,000 people across a country, say across Kenya, where you are, or Uganda, you can actually use those vaccines very quickly within 2 weeks. So, and in a targeted way, remember these were vaccines that were designed to immunize our healthcare workers. So, but the deadline there initially from the Serum Institute was April 13. The Serum Institute, as you rightly said, expanded the deadline based on their own analysis to July 13. Okay, so, and we shared that information with the country. So look, the initial shelf life was 13 of April. The Serum Institute is saying, based on the analysis, that you can actually use it to 13 of July. But please do everything. These are smaller donations. Do everything to use the vaccines as quickly as possible. So that is the situation. When you have a new product, like the vaccines that are coming out, they try to be very conservative and try to make it, people use it as quickly as possible, pending further analysis. And then when they do further analysis, they advise and they go on. So we can only go with the advice that the Serum Institute is issuing us, and we believe that is credible. I mean, we have to have a scientifically trusting element here to believe in that. So as we speak, most countries have used their vaccines that were shipped. As you know, some countries have complained that they cannot use it before the 13th of April. We are repeating just what you said, Peter, that look, the Serum Institute extended that, and we have documentation for that. So I think that is where I'll leave that question up. Maybe before I leave, I'll just say that we are in a very, in an emergency situation. And it is my appeal to all member states that when you get your vaccines, arrange and put on the right systems to use those vaccines quickly, so that we do not get into the issues of we get the vaccines and because of transportation, shipment in country, we didn't do that. We are at war with this virus, and we are doing our best to support countries as much as possible. Donations, okay, from the MTN, generously donated from MTN. So again, it is my strong appeal, whether the vaccines are from COVAX or from the AVAC or from any source, to use the vaccines as quickly as possible, because it is in using that quickly that we can save lives as much as possible and break the transmission chain.
Thank you, John. We now have the question that's coming from David Pilling with the Financial Times. And he says, the United Kingdom has suspended the use of AstraZeneca vaccines for under 30-year-olds. Given the median age in Africa is 19, is the balance of risk and reward still in favor of using the AstraZeneca vaccine on the continent, particularly in the younger age groups? And more broadly, with supply now a problem and the risk reward of vaccines coming under increased scrutiny, isn't the vaccine rollout in Africa now in something of a crisis? So that's from David with the Financial Times.
I think that, David, you are absolutely correct about the UK government suspending that. But again, when I do the risk analysis that I just indicated, if I was a young woman in Africa underneath 30 years, I would say, what is the risk of a blood clot if I take an AstraZeneca vaccine? The risk is 0.0, it's like 4 in 1 million cases. The risk is 0.0003. If I take my contraceptive pills in the morning, what is the risk? The risk is if out of 1 million young women below 30, about 500 to 1,000 may get a blood clot. So the risk there is even higher than getting the vaccine. Then I'll ask myself the question, if I do not take it at all and I get a COVID infection, what will happen? I mean, as I stated earlier, it will be like 165,000 deaths out of 1 million. So I'll balance that up, and then my answer and my response to the continent is we have to go with AstraZeneca. We have to continue to use AstraZeneca. The UK and other countries have choices of vaccines. We do not have a choice. I mean, the AstraZeneca vaccine, I mean, so the first thing, let me just say this very clearly, is that the risk, again, the benefit outweighs the risk. Second is we just don't have choices on the continent. Okay, a country like the United States will have about 4 vaccines: the Moderna, the Pfizer, AstraZeneca, Johnson & Johnson. We have nothing. Okay, we have the AstraZeneca, Johnson & Johnson will be coming online about the third quarter. The rest of the vaccines, donations that are coming in from different parts, the Sinopharm, the Sinovac vaccines, those are smaller amount. Those are not programmatic vaccinations. They come in 100,000 here, 200,000 here, but that it would not be enough to give us a programmatic target of vaccinating 60% of our population. I think that is what I mean. That would be our recommendation from the Africa CDC to member states, that go ahead and use the vaccine. The benefit outweigh the risk, even at that age group. And by the way, we do not have choices as we speak at this moment. I'm hoping that Kara, your question will trigger more partnership from the United States government so that they can donate us any excess vaccines, so that we at least have choices, and say to the young people below 30 years that, look, if you are below 30 years, you can maybe go get yourself a Moderna vaccine or the Pfizer vaccine. But for now, or Johnson & Johnson, but for now, we just don't have that choice.
Alex Winning from Reuters in South Africa has a number of questions. I'll take the first one and then come back to her later. So she says, has the Africa CDC spoken to Malawian officials since last week's press briefing to advise them against destroying the 16,440 of the AstraZeneca vaccine doses that they had been given by the African Union and which they said had passed their expiry? If not, would you like to take this opportunity at this press briefing to advise them against incinerating those doses?
Thank you. That is a very, very good question. When we engage countries, we're very clear. We send them clarity of information and also advise them to use the vaccines quickly. Also share the information with respect to that, the adjusted date of on the labeling to July 13. So have we since last week engaged with Malawi? No, we have not. And we will continue to encourage them that, look, the vaccines are very, very safe. Now, if I had no vaccines and I have vaccines that the Serum Institute says that the expiring date can be used up to another 2 months or 3 months or so, please, I'll go ahead and use it. You just heard from Peter about that. Even the vaccines in India, the Serum Institute is saying they have even more. They have extended even the expiring date to a much further date than the 13th July. So again, we are at a war with this virus. Let's use all the weapons that we have at our disposition to fight it as much as possible. And again, my appeal to member states is, if we are doing our own part of it to mobilize these vaccines, you do your own part and use the vaccines. And let's try to save lives and save our economies.
Thank you. We have a question that has come in from Esther Nakazi, and she is a freelance journalist. And she says, is Africa CDC getting any updates from any apps that are used by member states to report suspected adverse drug effects?
So we have not yet established that system, but we are establishing it now, what we call pharmacovigilance across all member states. But WHO Afro is working on that, and we exchange notes all the time. But in the coming weeks, you see that we will be having a continental approach that is regionalized, that the 5 regions of the continent will have system that can track adverse effects and report them. Again, we are building a ship and riding it at this moment. And of course, as you I promised you a few weeks ago that we have a dashboard. We now have a dashboard. And in the coming weeks, when we finalize our dashboard on tracking adverse effects, we'll bring it live and then also ask for your help in using it and advising us on if it is user-friendly and is giving you the good information.
All right, let's come back to the questions from Peter Mwai of the BBC. So he says, is it possible to know the final list of African countries that benefited from the MTN doses, and whether any other country other than Malawi and South Sudan have struggled with using the doses before expiry? And he comments that this information is not available from the portal.
Yeah, Peter, we can certainly, it's public information. We can find, share that, the 13 countries that received the vaccines. I mean, given the enormity of what we're doing, when we send those vaccines, we do not follow through and say, hey, have you used it? We expect that the dialogue that we've established before will enable countries to move forward. In countries that had concerns early on, came to us and we said, look, if these are small doses of vaccines, I think Nigeria had the most, 300,000, and they said, look, it doesn't look like we can use all of this before that. And we took that out and redistributed it to, Togo, Ghana. So it's really to encourage countries in your own capacity as where you are as an intermediary to the respective communities and societies to say, look, put these systems in place that can use these vaccines as quickly as possible. So the answer to that will be yes. Peter will be happy to share the list of the 13 countries with you at any time. So you can engage with our communication office and they will do that.
Okay.
And I thought we actually did in one of our briefings, but we'll be happy to share that again with you.
Okay, I think let's take our last contribution by going back to Alexander Winning, because she had a number of questions. And Alexander says, how do you rank vaccine hesitancy among the problems African countries are having with the rolling out of vaccines? And the other part of the question, could you confirm that the only supply bilateral deal that the African Union has signed to date is with Johnson & Johnson, and that would be for the 220 million doses with an option for another 180 million doses? And finally, could you give us an update on the talks that you are having with Pfizer, Sinopharm, and the manufacturers of the Sputnik 5 vaccine?
So let me, the hesitancy, I'm learning a lot from the community response. Before the vaccines were available, several months ago, and I shared the information with you on this platform some months ago, we developed and we conducted a survey in partnership with the London School of Hygiene and Tropical Medicine, where we asked a simple question as to if the vaccines were here today, would you accept it? The acceptance rate ranged from 59% to about 95%. And now, at that time, there were no vaccines on the continent, and even, I would say, in the world. And with the current vaccine and vaccination situation, we will be conducting additional studies because behavior is not static. Okay, what people thought of at the start of that survey, it can be very different from what the situation is today. And so it requires that we do that repeatedly so that we can use the information to engage the community appropriately. So unless we do that kind of an analysis, what I call a moving survey of behavior, I would not be able to rank where we are with respect to hesitancy. But what is very encouraging is that the countries that are listed that have taken up their vaccines, the Seychelles, the Morocco, the Rwanda, the Ghana, the Nigeria, it's a very good testimony that countries, that individuals may be hesitant, but they are taking up the vaccines. Okay, that is very, very good news for us. I think to the extent that countries have run out of using their first shipment of AstraZeneca and are anxiously waiting for the second doses to be distributed. Is a very good thing. With respect to your second question of Johnson & Johnson, yes, Johnson & Johnson is the only contract that we have signed with Harvard. I'm learning a lot personally as a public health expert in this space of discussions with other experts that deal with us in this, where you first of all have agreements, and then agreements lead to contracts. Until you sign a contract, and even if you have agreed with a company, it doesn't guarantee that you have it. So as we speak today, the contract that we have signed is with Johnson & Johnson, 220 million doses that are secured, firmly secured, with an option of an additional 180 million doses. The discussion with Pfizer, Sinopharm, Sputnik are at very different levels, and none of that is close to signing any agreement, any contracts with them. For example, I think WHO will be meeting on the 29th of this month to discuss the Sinopharm and the Sinovac vaccines. And I think that we remain hopeful that the discussion will lead to a pronouncement, a favorable pronouncement on the emergency use authorization. That way, we increase the pool of our recommended vaccines. I think until then, I can say that we are at very different stages of discussions with and it's still discussions, not even agreement with those companies that you listed.
Thank you, John. It's time now for us to hear your final headline comments, the key messages that you want to leave with us today.
So I just have one key message, Wayne, to leave with that. Is really call for, again, your support as a community, the voice of the community, you, the media, that when you engage with the different countries, one, encourage them to go to the Africa CDC platform, that is the amsp.africa, and take up their Johnson & Johnson vaccines, so that we can completely take off those 220 million doses of vaccines off the table. I mean, we can only rely on ourselves. I mean, that is just, we have to take our own destiny in our hands rather than wait for maybe donations to come from another country. We should really proactively get engaged, use those vaccines. Ministers of Health and Ministers of Finance should go in and work with us to uptake all of those vaccines. I think that is one. Second is my message, and last message is that encouraging through your own influential outlets that countries should, when they get their vaccines, do everything, roll up your sleeves and vaccinate. We are at war with this virus. And I think when you're at war, you don't act as you are in normal times. Use the vaccines that are available quickly, because each time you vaccinate an individual, you are minimizing the risk of death of that person. You are also minimizing the risk of potential spread of that. We see what is happening in Israel, where they are vaccinated at speed and at scale, and now they are beginning to look like they can even tell people to move around without masks. That we should be inspired by such behaviors, by doing the right thing and doing it in a timely fashion. That would be my appeal to all of you who are all in this fight together with you. And I think we will only win this if everybody, all sectors of the community, are engaged in this battle. The politicians doing the right thing, the policymakers doing the right thing, the media working with us as we've worked over the last 1 year and something, and of course, Africa CDC and the African Union looking for the vaccines wherever they are. Thank you so much, Wayne.
Thank you very much, John. That was Dr. John Kengasong, the director of the Africa CDC. Colleagues, it's time for us to close our briefing for today. I can see that we had a question from Paul Adepoju, which just came in. And Paul, if you still want the response to that question, please use this WhatsApp number to contact one of our officers. And that number is +251 945 502 310. and Nekeron, who is on the other side of that line, will be able to assist you. But otherwise, colleagues, thank you again very much, and apologies, sincere apologies for the late start. We will be advising you of any change in time as suggested by Dr. John earlier. So our next press briefing will contain that information for your guidance. But again, thank you very much for your patience. Thank you for staying with us. We've had excellent contributions, and it's really wonderful that you were able to stay with us for this time. So thank you again, and we meet next week at the same time.
And thank you, Wayne. And let me add my apologies to yours, that really that we'll fix this, and that way we'll adjust the right time for us to get our regular conversations. Thank you.
All right. Bye-bye, everyone. Thank you.